Welcome, everybody. I hope you had a good break. So our next speaker is Professor Nadia Bolognini from the University of Milano Bicocca in Italy. And she is joining us online. Do we have, yeah, it's connected, I suppose. Can you hear me, Professor Bolognini?
Yeah.
Great, so the floor is yours. Thank you.
Okay. Can you see the presentation? So, hello, good afternoon to everybody. It's a pleasure for me to take part to this first conference on phantom limb pain, and I wish that this is the very first conference of a long series on this very interesting topic. And I first would like to thank Max and his colleague for organizing this meeting in this complicated period, and I'm sorry to not be there with you. So in my talk, I will present and discuss with you the state of art of the research investigating whether or not non-invasive brain stimulation can be used as a treatment in phantom limb pain. As we clearly understand, it's now very clear from this meeting that the phantom limb pain is a complicated form of neuropathic pain, and likely it's potentially one of the most complex chronic pain syndrome. And we have seen the multiple mechanisms contribute to its manifestation, frequency, intensity, and so on. And as already said in the day before, we have about maybe more than 60 treatments available for phantom limb pain, but yet no one is widely accepted or clearly superior to the other. So we are still looking for some more successful way to treat phantom limb pain. And in this context, an interactive option is offered by the non-invasive brain stimulation. So we know from, there are many studies that have shown us that non-invasive brain stimulation, transcranial brain stimulation, is useful to treat chronic pain because it has some analgesic effect, and basically in drawing inspiration from epidural motor cortical stimulation, the main use of non-invasive brain stimulation to treat pain is based on the upper regulation, increase in the excitability of the motor cortex, because in this way it is believed, there is some evidence shown that upper-regulating motor cortex excitability has some indirect effect on pain perception and pain processing, likely, as you can see in this slide, likely through a modulation of pain modulating area, such for instance, by activating sensing inhibitory pathway to the thalamus. With respect to phantom limb pain, we can also think to use non-invasive brain stimulation, also target more directly maladaptive neuroplasticity. We have seen that many areas are involved in phantom limb pain, and the idea behind is that we may, that maybe phantom limb pain can be successful reduced if we target cortical representation. And as you can see from this picture, there are many areas that potential can represent a target for non-invasive brain stimulation, and so for affecting phantom limb pain. So, so far, two main non-invasive brain stimulation has been used in phantom limb pain. On one end, we have a repetitive transcranial magnetic stimulation and transcranial direct current stimulation. I go very fast on this slide because this morning, Lorenzo Diana has provided us an excellent overview on the mechanism of action of transcranial directed stimulation, which is the main non-invasive brain stimulation technique used in phantom limb pain. There are also some studies with repeated transcranial magnetic stimulation, and I just want to bring your attention of a main difference between these two techniques. That is why transcranial magnetic stimulation is essentially a neural stimulator tool, because it can facilitate the induction action potential. This is not the case for transcranial direct current stimulation that can affect neuroexcitability in a polarly specific manner, but without directly inducing action potential. By the way, both these techniques can be used to modulate cortical excitability, increasing or decreasing it with long-lasting effect, and these such long-lasting effects are often paired with behavioral effects. And transcranial direct stimulation has been used, preferred so far to transcranial magnetic stimulation phantom pain for different reasons. First, because it's easy, less expensive, it's easy to apply, and even to combine with a behavioral task, even less expensive with respect to transcranial magnetic stimulation. And also, at least in my view, the fact that it's a neuromodulator technique and has a very low spatial resolution, maybe even an advantage in the treatment of phantom pain, given the complexity of this kind of pain. So I will start. We were for the first to study, to explore the effect of the application of tDCS on phantom pain. And in our first study, we conducted 8 amputees with upper or lower limb amputation. We applied we did a single application of tDCS. I also call it one-shot tDCS. So we apply just one time tDCS, and we measure phantom sensation and phantom pain limb before and after the application of stimulation. We target 2 areas. On one end, we stimulated the motor cortex with anodal tDCS or sham tDCS. So anodal tDCS, I remember you, usually, typically, at the level motor cortex can induce excitatory effect and increase cortical excitability. And the motor cortex was chosen basically for the reason I said you before. So, namely, it's a well-known analgesic effect, and also considering the fact that substantial sensory motor reorganization represent a feature of phantom pain. On the other side, we also stimulated the posteroparietal cortex, because amputation-related changes were detected also at the level of this area. That is a very important area, key area involving body representation, pain perception, and corporeal awareness. And for instance, there are some anecdotal reports in the neurosurgical literature showing that the vascular or surgical lesion of the parietal cortex can even abolish phantom sensation. But in this case, for the parietal stimulation, we deliver both the anodal, excitatory, cathodial, inhibitory, tDCS, as to assess the effect of both polarity. And here the results. So as you can see, with respect to the application of the anodal tDCS for just 15 minutes over the motor cortex contralateral to the amputation side, you can see we obtain a selected reduction phantom pain that return to baseline level after 90 minutes after the application of tDCS. Instead, the same stimulation, the motor cortex stimulation, was unable to change some pain, non-painful phantom sensation, and telescoping. Instead, with respect to the parietal stimulation, we again find a very selective effect, because we found that the cathodial inhibitor, tDCS, was able to induce a short-lasting reduction of non-painful phantom sensation, and again, short-lasting because 90 minutes after the stimulation, the phantom sensation returned to baseline level, but in this case, we didn't find any effect on phantom limb pain, some pain and stopping. We then move to consider whether, multiple application tDCS could induce a long-lasting phantom pain relief. And this because we know from the literature, as also discussed with as also Lorenzo said in this morning, that multiple consecutive application tDCS seem to be required to induce a significant and long-lasting cortical excitability changes. This is because an enduring stimulation seems to be able, the only one to be able to promote the mechanism of synaptic plasticity. So we tested again 8 hypotheses, and then underwent a 1-week treatment with tDCS, with daily application for 5 days of tDCS. And based on our previous finding, we stimulate again the motor cortex with anodal tDCS. And now what we found was that on each daily session of tDCS, there was a reduction of phantom limb pain when the active, real anodal tDCS was delivered. And we did not modulate non-painful phantom sensation, but we also found an increase of phantom limb movement after the anodal stimulation with motor cortex. And of the great interest was that we found an association between the phantom limb pain relief induced by motor cortex stimulation and the increased ability to move the phantom. So the greater was the ability after tDCS to control the phantom movement, the greater was the reduction of phantom limb pain. And this in line with the data we have discussed in this day about a possible link between sensory motor plasticity, the ability to control the phantom movement, and the phantom limb pain. This is just to remind you, for instance, starting from the clinical observation that many amputees frequently report to feel the phantom in a fixed position and report cramping sensation as the main characteristic of the phantom pain. But we have also discussed all the evidence showing that poor motor control of a missing limb is associated with increased pain, and this seems to occur not only with respect to phantom limb pain, but it's been found in many other pain conditions. Also, we have seen that a large number of treatments for phantom limb pain are based on phantom motor execution and the induction of an activity in the sensory motor cortex. And finally, there are also some recent evidence that seems to suggest that phantom limb movements can even represent a protective factor for phantom limb pain, because it was found that amputees with lower level of phantom limb pain are those that can move more easily than phantom limb. Of course, we have discussed also of some different evidence, but it seems that our disassociation between increased phantom movement and phantom limb pain relief is quite in line with the literature. And we also, in the same study, found, as expected, that the 1-week treatment with tDCS was able to modulate in phantom limb pain in the long term. So even 1 week after the treatment, patients still report a reduced phantom limb pain, and also a reduction in the frequency of phantom limb pain paroxysm. And with paroxysm, phantom limb pain paroxysms, I mean the episodic increase in pain above the ground level of phantom limb pain. And there is another more recent study by the group of Camaramakinen that also assessed the effect of one single application, so again one shot study, one shot tDCS study, Over the sensory motor cortex, again, the anodal tDCS or the sham tDCS applied to the contralateral sensory motor cortex, contralateral to the amputation side. But this author delivered the tDCS during the execution of phantom and movement. And what they found was basically that immediately after the tDCS, the sham tDCS, so the placebo stimulation, there was an increase of phantom limb pain. So confirming other findings showing that sometimes movement can increase at the level of phantom limb pain. But such increase was absent after the delivery of the active stimulation. And also in the long term, even if they apply tDCS just for one session, they observe a reduction of phantom limb pain, also assessed on a daily basis by asking patients to report daily the level of the phantom limb pain. And this effect was long-lasting since it was detected at least for 1 week after the end of the treatment. This study was nice because they also investigated with fMRI the neural correlates of this tDCS effect. A main finding was that the author showed that the greater was the phantom limb pain relief induced by the active motor cortex stimulation, the lower was the activity, the activation, the primary sensory motor missing end cortex after tDCS. So it seems that phantom limb pain relief during the stimulation was associated with a downregulation of sensory motor cortical excitability contralateral to the amputation side. And they also found another interesting finding was that they found that the level of insular activity during tDCS was correlated either with phantom limb pain relief induced by tDCS, as well as with the downregulation sensory motor activity, and also the insular activity came out to be a predictor of the tDCS effect, of this tDCS effect. Another target that has been tented for modulating phantom limb pain was the cerebellum. We know the cerebellum is an important site for sensory motor integration, but it also mediates behavioral responses to nociceptive stimulation. And this study by the group of Tommaso Boggi of the University Statale in Milan, they used the cerebellar stimulation, applying an anodal or sham stimulation for 10 minutes for 5 days, so again a 1 week treatment. And what they found was basically that the cerebellar anodal stimulation decreased paroxysmal pain, phantom movement, and phantom sensation, but did not affect phantom limb pain nor the stump pain. And I want to bring your attention to the fact that they obtain effect on phantom movement, but they observe a reduction in phantom movement and non-phantom limb pain change. While we found that increasing phantom movement correlates with phantom limb pain relief. So this suggested that a sustained cerebral brain inhibition is not enough to modulate phantom limb pain. Likely a more specific effect on motor cortical representation is required to modulate at least this type of pain. And with respect to the repetitive TMS evidence, just 2 words, because as you can see from the slide, the findings were mixed. Some have a positive effect, some show some phantom limb pain relief, others do not. But the main conclusion is that, again, the excitatory high frequency repetitive over the motor cortex contralateral to the amputation side can induce some relief from phantom limb pain, but overall seems to be short-lasting, not maintained in the long term. There is also one study that tried the stimulation of the post or the contralateral parietal cortex, but did not obtain reliable effect on phantom pain. So again, this is like we are finding with tDCS. And more now we are there is an increasing interest to combine tDCS with a behavioral therapy. And so far, tDCS has been used as a standalone treatment. Now there is various groups that are trying to use tDCS as a add-on intervention to a behavioral training, with the idea that the combined use will be increase their effects, their individual effects on cortical excitability, and inducing more relevant clinical benefit and long-lasting clinical benefit. The idea behind is that with non-invasive brain stimulation, but also with, and in particular with tDCS, as also said by Lorenzo today, we can target the functional network more specifically, and this can be this modulation of the functional network activated by task may increase use-dependent plasticity, so increase the effect of the behavioral therapy. There is an increasing evidence that this might work, at least in the literature on motor learning in healthy individuals and in the literature in stroke patients. These approaches, there are few studies that assess this approach in chronic pain, and there is some evidence suggesting that the combined use of tDCS with virtual reality can improve, can help pain management. With reference to phantom limb pain, there are only 2 studies that have used this combined approach. In both studies, combined motor cortex stimulation with the mirror therapy, because the idea is that both the motor cortex stimulation and the mirror therapy may activate similar mechanism of action based on changes in cortical excitability in motor cortex, and so they could maximize the individual effect. So these 2 studies, however, give us some mixed findings. This is a very recent study where the mirror therapy was combined and delivered for 2 weeks, was delivered alone or combined with sham of anodal tDCS, again over the motor cortex contralateral to the amputation side. And what they found was that it seems that in their study they induced a greater phantom pain relief with the combined stimulation, so by combining anodal tDCS with the mirror therapy, and this reduction of phantom pain was long-lasting, still present after 12 weeks from the end of treatment. This study missed an arm with tDCS delivered alone, so we cannot conclude that the combined approach is really superior to the use of tDCS alone. However, the authors estimate an pain relief and relief from phantom pain of about 80% in the group that received the mirror therapy with tDCS. That is a very huge phantom pain relief as compared to the previous studies where tDCS used alone induced a pain relief of about 40–50%, so it's doubled the effect. Very different findings were obtained by the group of Philip Fregini, who also combined mirror therapy and even a cover mirror therapy delivered for 2 weeks, and they also, during these 2 weeks of cover mirror therapy, they also for 2 weeks applied anodal or sham tDCS over the motor cortex. But as you can see, they obtain substantially a pain relief in every condition, even with the cover-mirror therapy and the schema stimulation. So this looks like a very, very huge placebo effect. But they also, the interesting thing, they also measure changes in cortical excitability, and they found significant changes at the level motor cortex excitability only in the group that received the active stimulation with the mirror therapy and even the cover mirror therapy. And in particular, they found an increase in intracortical inhibition that was associated with phantom pain relief. They, as you can see from this slide, they found other effect on cortical excitability, but are some strange because they also found some effect with the schema and cover mirror therapy, and this is like because they stimulated to measure cortical excitability. They stimulated with TMS the motor end area in the affected hemisphere, but there were tested lower limb amputees. So this makes a huge difference mapping the end area than the amputee, the missed leg area. So in conclusion, we can say that so far the evidence seems to suggest that the transcranial non-invasive brain stimulation, and in particular the anodal excitatory transcranial direct current stimulation over the motor cortex contralateral to the amputation side, is able to induce, to promote a phantom pain relief. With respect to the combined approach, we cannot say we have not reached any conclusions, since we have just to study with that different findings, likely because the huge methodological difference. But for future studies, it will be important to keep in mind that the tDCS effect and in general the transcranial stimulation effect are task dependent. This means that some tasks may be more susceptible to cortical excitability shift induced by tDCS than the other. And so in our view, the choice of the task represents a major determinant of the efficacy of the combined approach, and may even guide the choice of the stimulation site, of the stimulation area, that not necessarily will be the motor cortex, slightly depending which task we want to combine with tDCS. And for the successful implementation of this approach, of course, we need to have better and improved understanding on one end of the analgesic effect of motor cortex stimulation, especially in phantom pain, and also the functional interaction between the analgesic effect brought about tDCS and the activity, task-induced effect on cortical excitability and plasticity. We also need to explore the efficacy of other non-invasive brain stimulation techniques, for instance, random noise stimulation, or even pair-associative stimulation, which has the advantage that allow us to target functional connectivity and of using paired sensory stimulation with cortical stimulation. And another future development of this line of a research could be the use of non-invasive brain stimulation even to prevent phantom pain. All the studies I show you like this brain stimulation in patients with chronic post-amputation phantom pain. But we don't know if we can even use this technique to prevent for phantom pain. So for instance, the transition from acute pain to chronic pain. And this, I think, is another area that is of very interest to explore in the future. I conclude my talk, and I would like to thank you for your attention, and I would like to thank my collaboration, especially Angelo Maravita and Filippo Freni, that collaborated a lot with me in the study of in the search of an optimal way to stimulate with transcranially the brain for the phantom limb pain relief. Thank you for your attention.
Thank you, Prof. Bolognini, for this nice presentation, and we have a few questions for you. I need to go and read them. Do you think that PLP may partially be patient's manifestation of their inability to move the phantom?
Maybe. Why not? And I mean that the ability to move the phantom, its relation with phantom limb pain, and we see that it's very complex, and we have evidence in the study of Professor Mackin that movement can even increase phantom limb pain. We know that some patients feel that the feeling of a phantom in a fixed position seems to increase at the level of the phantom limb pain. And we have also seen that there are many psychological factors that may affect the way the phantom limb pain is perceived in a report, and also the link with the movement. So this is my opinion in this regard.
Okay, thank you. So we have a lot of questions actually. The next one that I'll take is this one. Do you think that if you targeted the foot motor area for an adult tDCS for the lower limb amputees, you would have gotten even better results?
Yeah, keep in mind that first, tDCS has very low spatial resolution. So we usually say we applied it over the primary motor cortex, over the end area, but in fact it's a very, if you have attended the morning session, the demonstration of Lorenzo and Diana, we see the electrodes are quite large, and so it's more appropriate to speak of stimulating sensory motor cortex. In many of the studies I told you, the author say in the paper they applied the electrode over the end area, even in lower limb amputees, and they got a resolution pain relief in this case. So this, of course, with tDCS, the issue of targeted the leg area and the end area, it's not a problem. With TMS, everything changed. The study by training, measuring motor cortex excitability is report some mixed effect, probably because they target the end area in the contralateral hemisphere, contralateral amputation side, but he has only lower limb, and this makes a huge difference, if I understand your question.
That was what the question said. So I guess the person who asked can maybe go a little bit deeper on the panel discussion. We got some many more questions that we will address later on in the panel discussion. Thank you very much, Professor Bolognini, and I hope you can join us later on and we can take those questions.